President-elect of AIOS. He will again be joining shortly. With me, my co-moderator, Professor Namrata Sharma, who is the Honorary General Secretary of AIOS. And today we have with us Dr. S.P.S. Grewal, who is the Director of Grewal Eye Institute and Consultant Cataract and Refractive Surgery Services at Grewal Eye Institute. He is a known figure, world-renowned figure in cataract and refractive surgery. He has received various awards, which includes the Colonel Rangachari Gold Medal, the Santevision Award, the many publications, more than 150 national and international publications and instruction courses. He has received the Achievement Award at the American Academy of Ophthalmology, International Scholar Award at the American Academy of Ophthalmology. He has received Best of Show Awards at AO in the year 2014, 2015, 2016, 2017, and two papers he had in AO 2017, which were related to this and which received award. So we welcome Dr. S.P.S. Grewal. We also have with us Dr. Sartaj Grewal, who is Consultant Cataract and Refractive Surgery Services at Grewal Eye Institute, and he has completed his MD Ophthalmology from RP Center AIMS, and now currently practicing as cataract and refractive surgeon at Grewal Eye Institute. He is also adjunct assistant professor at the Feinberg School of Medicine at Northwestern University, Chicago. His areas of expertise include complex cataract surgeries, ICLs, Smile Loop, Smile Extra, various device-related innovations he's interested in and he keeps doing. And when he's not operating, in his free time, he's an avid cyclist. So he's a fitness freak. And so we welcome Dr. Sartaj Grewal in this live Surginar. And now we would like to connect to Dr. Grewal, who will be starting the first case and would like to know the details of the first case. Can we have the details of the first case, sir?
Yeah, gel and telescope. Is the screen visible?
Yeah, we do have the microscope view now.
Good. So I'm doing the telescope at the moment.
Regarding the case,
the first I'm doing the first eye, right eye first. He is 24-year-old male. The K1 is 45.8, K2 is 47.2. His refraction is minus 8.5 with minus 1.75 cylinder, with a Phakic of 554 microns, a Y2Y 10.7, and the AC depth of 2.92. And the length lifted is minus 11 square with minus 1.5 x's, and the residual expected residual is minus 0.25 with plus 0.523 cylinder. So that is, we are very practically coming up to the ametropia. So we are starting with the
I'll just request the admin team to clear the voice. The voice is slightly unclear. It's not very clear. The technical support, can you do something for the voice?
Put the mic in the mask. Put the mic closer. On the mask, edge of the mask. Flip it on the mask. Is it better now?
Sir, we can't hear you clearly.
Very good. Can you see the microscope view?
Yeah, I can see the microscope view, but your voice is very low. I think they need to do for the audio. pupil with a nice glow. Unfortunately, the audio is not very clear. The
But I'm starting. Can I have a little gel on the corner? So I'm starting. You can see that the cluster has been done and the axis has been marked. I'll be first making the side port incisions. Relax, Privanshu. You may feel a little bit of springy sensation just for a few seconds. That's excellent. Keep looking into the light. That's very good. Excellent. Very good.
so after making the side port, you have injected the viscoelastic. Which viscoelastic you use?
Yeah, now I'm injecting the viscoelastic. And now I'll be making the main incision.
Which viscoelastic you use, sir, for phakic implants?
Methyl cellulose.
Methyl cellulose. And what's the incision size that you use?
This is 2.8.
2.8.
And now I'm loading the implant. And the loading of this is something like that for the IOL only. It is a similar cartridge. So this is the cartridge, and you can see the Phakic IOL here. So tuck in one edge, then you tuck in the other edge, gently slide it to put it into position. Make sure that these holes are exactly in the center, and gently close the butterfly. And this is the injector. So it clicks into the injector. Now this step is very important. I always like to do it under supervision so that you push the implant, and at this end you be very sure. Now you need to focus on this point. This is the edge of the plunger. Make sure that the edge of the haptics is not coming over the green part. So this I'm sure. I'll put the lens. You can see the haptic has folded a little bit. That means it's absolutely fine. I'll go on to the other side and then again press it and make sure that now I'm very sure that the haptics are not coming between the injector and the plunger. So once I have loaded it, I go back
And you also see a smooth movement, so that helps us to know that it's very
Yes, that is exactly.
yeah.
Sorry, I missed that, sir. But which viscoelastic do you use for prior to
Methyl cellulose or all the steps like this.
methyl cellulose? Okay. I think the biggest advantage of this lens is that you don't have to learn how to inject it and then how to actually place it in the cartridge, because it is so much like the cartridge of intraocular lenses. So that learning curve is not there at all.
Very true.
And especially for the anterior segment surgeon, there's not much of a learning curve in it. So you're using a similar cartridge, you are loading it in a similar way. So that makes it a huge advantage.
And sir, this is 2.8 millimeter incision, and you implanted wound assisted, right?
Yes, sir, this is 2.8 incision.
Yeah. What do you feel the difference in terms of tucking of the foot plates when you compare it with the Collamer lens with these hydrophilic acrylic ones? Any difference you feel? Any ease or any?
Can you just a minute? Can you repeat the question? Let me put in the fourth. We have put the
Yeah.
So Rajesh, if I can answer that, I feel the haptics are a lot more stiffer as compared to the Collamer lens. The advantage of that is that it folds and unfolds more predictably. It doesn't somersault if it's a softer material. And the way you manipulate, I mean, it just makes it easier for you to manipulate it, because it doesn't spring back when you do it, it's there. So I think those are the advantages. The material is hydrophilic.
Yeah.
I 100% agree with you, ma'am. The handling of this is much easier. It's a little more rigid than the Collamer one. That makes the handling very easy, and pushing off the haptics under the iris becomes very controlled, and the vault is more predictable. You don't see the variations in vault with this. So I have put the lens in position, and now I'll remove the viscoelastic.
The design of this lens is very much like the Collamer ones, with a central aqua port.
I agree with you, because with the space that we have in the posterior chamber, I don't think much variation in the design will be possible with the limited space in which we have to work and put the lens.
True.
So what about the size of the central hole? Is it the same as the Collamer lens? Or?
No, with that lens, the wound is bigger. For that, you need a 3.2. This one you can manage with 2.8 incision. So I'm now injecting pilocarpine.
So you inject pilocarpine in all your cases?
Yes, all the cases, and I would wait a little bit to make sure that the pupil has started moving. The axis is absolutely fine. And then
So the axis, are you monitoring it on the calistro?
Yeah.
So can we see the screen of your operating microscope calistro monitor? I think then we can also, because we can't visualize the axis.
I get your point. Screen dikhana hai wali.
So if they show the screen and focus, then yes, I think now we can very well appreciate the fact that the three blue lines, and the line which is present on the lens are absolutely parallel to each other. Perfect. I think showed very well, sir. Very well.
So that's the end of the right eye, and we'll be moving on to the left eye. Lights, please. Thank you, John. We have done with the right eye. We'll be starting with the left eye now. Yes, doctor.
So you do bilateral together, right, sir?
Yes.
So I think there is a variability in this. Some people like to do one eye and then do the fellow eye at a later date. Some people do one eye and then do fellow eye 4 to 5 hours later. And some people just do bilaterally on the same day. So you think, do you like to keep some time interval, or at the same time?
I, as a standard practice, would like to do sequential, same day sequential both eye surgery.
Okay.
It's much more convenient for the patient. It's much more like they have to make one visit, they continue with the drop. And I really don't see the advantage in doing it in 2 stages at 2 different places.
So did you operate on a 3D RT view system? Because I see you wearing glasses, dark glasses.
Yeah. This is on the RT view. So I do all my surgeries on this, and I do all my surgeries with the 3D. I haven't used the eyepieces for a very long time now.
Okay. So
it's a huge difference. I wish there was an option to have a 3D transmission, but that is not possible at the moment.
Yeah. No, even when you're operating, it makes a huge difference with the 3D glasses. Everything becomes a little more magnified. Also, I think for patients who are undergoing refractive surgery, such as ICL, you can always decrease your illumination. So, although the illumination decreases for the patient, but for the screen, it remains as bright, which the surgeon is watching. So, that's a huge advantage, especially for these patients.
Absolutely. The illumination is excellent. The magnification is huge. And then the best thing with RTView is that as you increase the magnification, you don't lose the depth of field. The depth of focus is tremendous, and the 3D is, the eye looks so deep, you don't have any issue in handling the tissues. Here also, like when you're putting the haptics under the iris, it's so convenient. You can actually see the plane and in detail. So it makes it very precise without much of a handling or trauma to the surrounding tissues.
Quite right. I think those 3 lines, of which you see on your screen, they tend to get a little. The distance between them is less when you look at the 3D, as opposed to when you look at them through the eyepiece. And so then that also helps you to refine your axis of the lens in a more. It helps you to fine tune it in a much better manner.
And the other advantage is that everybody in the room can see it, 3D and see it. So it's a fantastic thing for training purposes.
So what is your post-op regime for cases of phakic lens?
Practically same as cataract, steroid, NSAID, and lubricating.
Okay. So Rajesh, you do the cases on a different day or on the same day, both eyes?
Same day, same
different day.
You do on a different day.
Yeah. Like what I'm doing now is my standard practice.
Okay. So the other lens is also toric, or is it a spherical lens?
There are very few patients where you need spherical lens. Otherwise, majority of them have some cylindrical, and I'll prefer, even if it is a 1 cylinder or a 0.75, I'll prefer a toric. So you can have the microscope, please. Callisto ready, please.
So do you use some anesthetic with a dilator like a phenocaine or like a
Yes,
down
yes,
in cases?
yes, yes, please. All cases.
Okay.
Dhanshu band na kariyo, okay? Please keep it open. There will be no pain. Very good. Chilling.
Another advantage what I have felt with these acrylic implants, which are made here only in India, you can customize it and you can have you can correct higher astigmatism, you can correct higher refractive errors. So all these things can be customized because these are
I
manufactured.
think I have used up to 28 diopters.
Yeah. So that's a big advantage. In some of the cases wherein we used to think that we have to do bioptics, say for 24 to 26 diopters, you can correct by only phakic implant.
So now for the left eye, the refraction is -7 with -2 cylinder. Phakic is 550, Y2Y 10.7, AC depth 2.9, and the implant selected is -10 with 2 cylinder.
What's the lowest cutoff for AC depth for you, sir?
2.8. That is what I asked.
Okay, you always stick to that.
Launch light dekho, please. In the middle of this. Lights off, please. हो गया cluster? Done.
So I think some time is taken for the cholesterol to register. Can we see the screen? If we can see the axis where the lens has to be.
You have to see the cluster screen. दिखाना जरा. Can I show the cluster screen?
Yeah.
Light देख दे रहना जी, please.
Yes, sir. I think we can see.
Yeah.
Yes. Okay. Perfect. Can come back on the microscope.
So we start now. I'll be making the side port incisions first.
So I think here when you start or beginning to start, you have to unlearn your phaco a little bit because everything here gets directed towards the roof and not towards the floor, all incisions, because there's a clear lens which is sitting there.
So this is, I'm doing the dilator and
the anesthesia part, both combined together.
yes.
So we tend to, at least I tend to use Helon for this step. Rajesh, what do you use? Just by
I use cellulose.
Methyl cellulose. Okay.
Methyl cellulose. Yeah.
It's every. I mean, it's a personal choice. I like to use Helon for this step. Some people like to use methyl cellulose. So.
You can use, I have tried Helon also.
Mm-hmm.
The advantage with Helon is that it comes, the evacuation is very good. It comes as a single course and complete. The disadvantage is that it makes your handling, it makes the surface of the implant very slippery. So you have to kind of learn to use it.
And even the tucking of foot plates beneath the iris may not be that.
Yes. Exactly, because of the higher viscosity and.
Yeah.
So this is the most crucial step. You can see the plunger, and now it is touching the.
Yeah.
And now you press it, so it is not engaged into it. Then go on to the it is clear, because if at this stage the haptic gets trapped between the injector and the piston, then you will have a tear of the.
So it was very clearly visible.
Saline gel. Lights dekhte rehna cha. Keep looking into the light, please. Very good. Excellent. Very good. So at this stage, it's important to make sure that it has unfolded completely. Then I'll go between the cornea and the implant, and I'll inject viscoelastic and also express the viscoelastic between the lens and the implant so that I get more space in this. So I'll keep inject, press it a little bit, and then again inject and have more space for me to work.
So there is a question on the YouTube, and they just want to know what is the ICL size that is being, what is the size of this, not ICL, but size of this phakic lens. So this is the phakic lens from Biotech, and what is the size which is chosen? So I think the size would depend on the white to white measurement you send to the company, and the manufacturer himself calculates depending on the parameters sent, which is the AC depth, the white to white, as well as the power of the lens, because the thickness of the lens will vary accordingly. Then there was another question that YAG-PI is not there. So in all these cases of phakic IOL implantation, where we have a central hole, I think.
If there is a central hole, you don't need it. And that's a big advantage.
Yeah. Sir, in hyperopic, if you are using a hyperopic phakic IOL, would you still do a YAG-PI, or would you still not have to use it?
I don't have experience as of now, so I won't be able to comment on that. But if with the central hole, looking at the whole concept, how it works, I don't think there should be any need, or I don't think the need for LI is related to your AC depth or a configuration of the anterior chamber.
Yeah. Also, there is a question that there is a central hole here. So do the patients, they complain of seeing any shadow or anything like that with this, any other phakic lens? So I don't think patients...
Let me answer. That's a very good question. There are two answers to that. First is, do the patients complain? The answer is no. Do they experience? The answer is yes.
So if you actively ask them, then
it's a single translucent ring which is seen at a particular angle. It is not something which is all the time. There is not like the ring that you have with the multifocal or trifocal lenses.
Yeah, absolutely. This is the most correct way of telling this thing, because if you ask a patient, then if the patient thinks, then the patient will say yes. But almost most of the patients, they don't complain for it. Very few patients complain for it.
So again, there is a question that do we customize the phakic IOL size according to the AC depth? And yes, to some extent it is customized. But
now the process of calculating it is that once you have all the parameters with you, then you go to the website of the biotech, and at the website you fill up the diameter, whatever the information is required, and it suggests you which particular model and two or different powers, and then it shows you which will be the most optimum, and then you select, and then you reserve at that time only. So there is not much of a decision making on the part of the surgeon. The only thing that as a surgeon one has to make sure is that your collection of the data is accurate.
Yeah, I think that is the most important thing. And in that, I think we do IOL master also for all our cases. Although having said
we do IOL master, we do the Lenstar, and we do the Pentacam, and we do the Cyrus T for all the cases.
Okay.
So this is important that at the end you make sure that the pressure is not too high. So now the pressure is okay, and that is we complete the surgery. Callisto, you can show the Callisto. Keep looking. Yashi, keep looking into the. Can you show that?
Yes, we can see it, sir.
Yeah, absolutely on the central line. It's very well aligned.
Bang on. Bang on.
Bang on.
So thank you so much, Yashi. Dressing, please.
I think with this central aqua port, most of the times now patients don't have high intraocular pressure. Because gone are the days when earlier we used to have some patients having high intraocular pressure because of the
Yes,
getting
it used to be a problem.
Yeah. Viscoelastic used to get trapped in the vault and all those issues. Now nothing is there because of the central aqua port. So that's a big advantage.
The patient is
Any
going.
questions, you know?
Patient is going to be bilaterally bandaged. So when do you open this bandage? Just before the
before they go home, and another 45 minutes or 1 hour, then then all these cases will come down to the OPD, and then they do a NCT, check the pressure, and then I examine on the slit lamp, and then they go home. That's a standard procedure.
Okay.
And then we have dark glasses. We give them dark glasses to wear for 1 day.
Okay.
So thank you so much, sir. I think that was excellent, of course.
Any other questions?
More important than the elegant surgery was the so many points which we picked up, which have also asked questions and which are going to be very useful for everybody. So
I mean, these patients are very demanding actually. So we have to, as sir was pointing out, these finer points have to be, taken care of so that the outcome is good.
Sir,
because
let me add one thing at this moment. Every patient is demanding. Let's not be confused about it now. Things have changed with now each and every patient is demanding, and we have to be on our toes for each and every patient, and we have to give our best to each and every patient. It's now very focused
that's very true. That's
work
very true.
in the OPD and surgery you have to do. That is what my is do less volume, but be fully focused and try to satisfy them fully.
Very true, sir.
So it will take a couple of minutes before the second case is ready. Meantime, I would just like to briefly sum up what I did. I make 2 side ports with the MVR angle blade, which are almost at 180 degrees to each other. It's when you're making this incision, it is very important because it's a phakic eye. It's very important that both the blades go horizontal. You don't go like this, you go like this. Then I use the Zalocard and Anvilin mixture for the AC, and that is you need to tell the patient, because when you inject it, these cases are under topical anesthesia, so there's no block given. So when you inject in the AC, they do feel a little bit, so you need to tell them that you will feel a little bit or it will sting a little bit for a short time. Then viscoelastic, good viscoelastic, because if you can make the eyeball reasonably tight, your main incision will come out to be perfect. So then I make the main incision, load the lens, which is very easy. It is just like a IOL. And after loading, then you insert, put it in the AC, rotate it to the axis, which usually is very little rotation. And then one by one, tuck the loop. You with your instrument, you go right in the end, then pull the lens towards you, leave it and quickly grab the next and pull it a little bit, then quickly go ahead until when you reach the end, then you slowly pull and tuck it under the iris. You have to be very careful when you are handling a haptic with a hole. Otherwise, if you're not careful, you may put the tip of the spatula through the hole, and then it's very difficult to take it out from there. So be sure that the haptic which has a hole, you are handling it in such a way that you are avoiding the hole. So my standard practice, I'll go the leading left first, then the leading right, then the trailing left, and the trailing right. That is my standard. And then removal of viscoelastic should be complete. I will turn the IA at 90 degrees and keep the outflow over the central hole, and then it removes the viscoelastic between the implant and the lens also.
That's
Right.
that's a very important point. The direction of the flow.
There's
Yeah.
another question, sir, that if your AC depth is higher, which can occur in high myopes, do you have a surgeon correcting factor for it, or whatever we feed into the?
No, whatever the website calculation does it, and we didn't have any issues with that. We never felt the need to do a manual adjustment so far. So with this, I pass you on to
Yes.
Dr. Sataj, and then maybe at the end we can have few question answers if required.
Surely. Thank you so much, sir.
Thank you, sir.
So, Sartaj, you are ready? Sartaj is also doing on a 3D with the RTU system. Can we have the patient details?
Yes, patient is a 20-year-old female. She's actually highly anisotropic with a power of -22 in the right eye, and she's inotropic in the left eye. So we're planning an ICL, Phakic IOL in the right eye today.
Okay, so you will be showing only one eye?
Yes.
What's the age? What's the age of the patient?
20 years old.
20 years old.
So
She
with
is amblyoptic in this eye.
with the 22 diopters, is she amblyoptic or she has?
Yes, she's amblyoptic. So we're planning some amblyopia therapy after this. And let's see.
So the AC is going to be very deep. What is the axial length?
Yes. The axial length was 33 millimeters, and the aqueous depth is 3.5 millimeters.
Okay. And is this being done under topical anesthesia? Obviously, anybody would be scared to, block such a patient.
Yes, exactly. This is under topical anesthesia. So we have a -22 diopter lens, also one diopter cylinder. It is a 13.5 millimeters lens, 13.5. So all the data seems correct. Let's proceed.
It's a spherical one?
It's a toric.
It's a toric.
There's a one diopter of cylinder.
Okay.
You can do that later. No worries. We'll do it later. It's okay.
Gently making the paracentesis incisions. Injecting some xylocaine adrenaline to keep the pupil nice and dilated. And yes, you want to be gentle, not too forceful. Injecting some viscoelastic. I don't like to go too far in with the tip, just in case the patient moves. Stay at the wound.
And this is also methylcellulose, right?
Correct, sir. I like to use a tooth forceps to just grab onto the wound, and then gently make a 2.8 millimeter incision. Do extend it just a little bit, making it trapezoidal. So then we go ahead and load the lens. The important thing to remember is that unlike the star lens, over here, the leading haptic, the port will be on the left side. I've actually seen sometime someone get that incorrect and end up with a lens that was upside down. So it's very important to, overcome muscle memory and actually focus and make sure that the orientation of the lens is correct. But yeah, loading the lens is quite easy. And then as sir already pointed out, we make sure the haptics are tucked away and not trapped between the plunger and the cartridge.
Yeah, we can see a very smooth movement. That
It's very smooth. Just a little more viscoelastic.
So this is again 2.8 incision, no? I think that is another advantage.
2.8 and a wound-assisted implantation.
2.8 wound assisted, and in all honesty, these guys have a special delivery mechanism that can actually go through 2.2 also. So the front loops are already tucked behind the iris. So we'll go ahead, gently rotate the lens.
No, so okay. So the loops have gone behind the iris. Was it done inadvertently or
Nope,
this is
intentionally.
Huh?
Intentionally. That is one thing I absolutely love about this lens, that it actually gives you enough control to unfold it very gently. And most of the times you're actually able to get those front two haptics below the iris, which saves you a lot of time and stress later on.
Okay. Because with the columnar lens, although it is possible, but it is difficult to do because it's a
It's
softer.
very difficult. Exactly. With the columnar lens, you're so afraid of damaging the lens that you don't want to manipulate it too much. With this lens, you can be far more confident.
So now I think you're going to rotate it in the axis of its toricity. Can we now see the cholesterol? The callisto screen, then we can appreciate that better.
And it's repositor.
Can we see the callisto, please?
Yes, so I can actually see the overlay of the callisto.
You can see, but we can now we can see because they're focused onto the screen.
Okay. Just a gentle nudge and
Yeah, it's there. It's there.
I will inject some pilocarpine. I like to use pilo at this stage to just get the pupil down. It reduces the chances of the IOL coming up again.
Okay. So there is a question on what are you using to monitor the axis? So we are using a Callisto device, which is an image guided system incorporated in the operating microscope, which was shown here for monitoring the axis. And there is another question, Sartaj, do you use home eye drops post-operatively in these patients?
No, we do not use any Midriatic post-operatively.
So Rajesh, do you use any homide or?
No, I don't use any Mediatic, any cycloplegic after phakic implants. There are a couple of reports also we read Zavalia, and most of the people have stopped. They don't use any cycloplegic or Mediatic after phakic.
Okay, so that was super fast, Sartaj.
Yeah.
Thank you, ma'am.
I think in 7 minutes, as I was monitoring this thing, it was over. But I think, like you said, it was also because every step was done so well, and two of the haptics were already inside behind the iris.
Yes, that saves a lot of time.
And pilocarpine you put in all your cases?
Yes, we do. It does reduce the vault a little bit on day one, but still, it's worth it. It just keeps the lens and the entire anterior chamber very stable on the first post-op day.
Another thing we could have done, we didn't show on the Callisto, was the distance between, on the intraop OCT, the distance between, maybe you can show it here if it's okay. Distance.
So our article does not have intraoperative OCT, ma'am.
Otherwise, we can, see the distance
yes.
between the phakic lens and the wrist line.
It's a very helpful tool for these patients on day one. You can immediately check it.
Sataj, what is your post-op vault which is acceptable, like the lower limit and the upper limit?
So usually, I'm fine with anything above 150, 200, and anything that goes up to about 900.
Mm-hmm.
But again, it will largely vary also, how is the anterior chamber depth of the patient. Usually patients who have deeper ACs, I will prefer to err on the side of a larger lens. Patients where the aqueous depth is less, I will always try to sort of err on the side of a smaller diameter lens.
Also, you were using the coaxial of the irrigation aspiration of the whatever machine, whether it was Centurion or whether it was Signature Pro. But the question is that, do you lower your parameters, or are the parameters same as that for cortical aspiration?
The parameters should be the same as you use for viscoelastic removal during cataract surgery, because when you go in with the coaxial, you already have the IOL over there, so you're not really worried about touching the capsule, and you really want to try to remove that viscoelastic as well as you can. So the settings should be high. The settings should be as high as possible for the viscoelastic mode that you would normally use for cataract surgery.
Okay. Okay, so I think that was very useful. I think I have asked all the questions which were there, at least on the YouTube and the Facebook. And there were a lot of people watching, and the advantage of making it live on Facebook, YouTube is that even without having to register, they can just access it as and when, whatever they are doing, if they are even slightly free. So that was excellent, Sartaj. You just finished in 7 minutes, 10 minutes, the whole thing. Rajesh, would you want to comment before we close?
Yeah, just going to the vault only, like if it's a toric implant, if it's on the higher side, it's still acceptable. But if it's on the lower side, the risk of rotation will be there. So lower vault, like, 100, 150 or something. Sometimes in spherical, 150 vault may do. One can continue. But with a toric implant, the risk of rotation can be there. So these are some of the things that we have to keep considering. And I mean, there's no hard and fast rule, but one may even follow up the patient and see whether it's rotating or not. If it's not, then it won't rotate in all the cases. So all these things to keep monitoring during the follow-up. So very nicely done surgery, Sartaj. Very smooth, and I can see it's really a treat to watch, and gives a great feeling, watching you doing such wonderful surgeries.
Thank you, sir. Thank you so much.
Yeah. Thank you so much. And there is a question which has come up just now, but I think let's answer it because we've still not closed. What are the pre-operative investigations that you would do for a phakic implant?
So starting off with just visual acuity, a thorough slit lamp examination. You want to check the lens, make sure there's no cataract at the moment. Then in the sort of machine-based investigations, I would recommend Pentacam. You want to make sure that the topography is fine. You would need biometry, definitely. We do LensStar and IOL Master for both patients. We do Osiris T, which is another form of aberrometry. So we'll get white to white from the LensStar, the IOL Master, and the Osiris T, and we'll do it manually also once just to corroborate. Then a dilated fundus exam, thorough periphery checkup of the retina is a must with these patients because they tend to be high myopes. An OCT macula for good measure is always good to keep it in case any untoward incident in the future. And a thorough cycloplegic refraction along with the subjective refraction is about all you need.
So thank you, Sartaj. The way you answered, I was reminded of your postgraduate days. As if you're answering a Viva question, but you did really very well. So thank you.
And let me thank you so much, ma'am, and let me express my thanks to the AIOS and the biotech for making it possible and taking it to a good number of our colleagues and fellows. Thank you so much, biotech and AIOS.
Thank you.
Thank you, sir. Thank you, Sartaj.
Thank you, sir, for always heeding to our request for doing a Surginar. Always a pleasure. They're always so crisp, to the point, and there are always points, which have to be learned. So thank you so much for always being there. And thank you, Biotech, for supporting this. We would also like to thank our AIOS team at the headquarters and the audiovisual person who does it from Swarnim. Mr. Gaurav and his team, thank you for doing this. I think they do it really very well. They have learned gradually what to focus on and what to do. And I would also like to thank my co-moderator, Dr. Rajesh Sinha, who's the treasurer of the All India Ophthalmological Society. So thank you, sir. Hope to have you again in another Surginar. And thank you, Sartaj. Thanks.
Thank you.
Thank you, ma'am.
Thank you.